Welcome back from Thanksgiving, everyone. And we're delighted to have a very exciting agenda for today. We'll be welcoming one guest from across town, and then that'll be followed by Dr. Ron's presentation. So it's my privilege to introduce Howard Sesso, whom many of you know well, and whose work really touches on a lot of what the McCance Center is about. Dr. Sesso is an epidemiologist and studies the prevention of cardiovascular disease, as well as other chronic diseases, with a particular focus on hypertension and obesity. And I think that's one of the major reasons why his work is so central to what the McCance Center wants to achieve. Dr. Sesso is Associate Director of the Division of Preventive Medicine at the Brigham and Associate Professor of Medicine at HMS. So Howard, I'm delighted to turn the platform over to you.
Thanks, and hopefully everyone's able to see this screen share at this point. And so it's a pleasure to be here this morning. Hope everyone had a good long weekend or longish weekend. And I'm pleased to be here. I'm really excited actually to talk about some of the large-scale trials that our division and I've been involved in over the years that have largely been focused on dietary supplements and its relationship with cognition and brain health. And I say to the cosmos and beyond, we'll be talking about some of our other trials in our division, but also finishing up with our recently completed Cosmos trial and some of the promise that's there for data, for sharing, some other opportunities for grants too. So in terms of potential conflicts, these are my own opinions relevant to this presentation with regard to Cosmos in particular, this trial. There's a funding that's been received from a combination of NIH, Mars and Bioscience, or Mars Edge for pills and packaging, infrastructure support, as well as Pfizer, which is now GSK Consumer Healthcare, for pills and packaging related to the multimineral component of the Cosmos trial. So, I'm going to frame a lot of the talk today around dietary supplements. And, there's this challenge that we have. My areas of interest cover many, not just hypertension and obesity, but also nutrition, aging, and just how do we improve health over the long term, especially as we get older. And, when we think about, I'm sorry to pick on a tomato, hopefully no one's particularly partial to a tomato here, but I think for any food, we have this challenge, right? We look at a food like a tomato and we ask, if there's health benefits from eating a tomato, is it because of the tomato? So is it somehow related to the food matrix somehow? Or is it a function of what you eat with a tomato? So is it the dietary patterns that you have? And this is where nutritional epidemiology has come into play over the years. At the same time, a lot of the people would argue, especially from the observational studies and not clinical trials, there could be other factors that are coming into play here. Those who are choosing to eat tomatoes might be different, not just with regard to the dietary components that they have, but other behavioral factors that could come into play. And finally, rather than the tomato, maybe it's a specific nutrient. Maybe it's something pertaining to lycopene or the fiber components of a tomato. So maybe it's something about the nutrients or specifically the supplements that could come into play here too. What I'd like to do for this talk is actually to initially frame things around one of our existing trials that I co-led with Dr. Mike Gaziano called the Physicians Health Study 2. This was a trial that was of nearly 15,000 US male physicians aged 50 and up. Mean age was about 64 coming in, and this was started back in 1997. So as you can imagine, this is now an aging cohort. It's actually a large, simple 2x2 by 2x2 factorial trial that was testing 4 different commonly used vitamin supplements at the time. So it's beta carotene, vitamin E, vitamin C, as well as a multivitamin. Now, one thing that our division does that's actually kind of neat is that we do our trials predominantly by mail. So these are great because it helps to keep the cost down. What's nice about doing work in dietary supplements is that they don't have the same types of rules and regulations around some of the prescription meds and phase 1, 2, 3 trials that you might do. So we send out these, as you'll see, calendar packs that go around that can be done entirely by mail, US based. The other thing that's unique to not just the Physicians Health Study, but to the other trials that we've done with our group is that we typically do, even for our larger trials, is a placebo run-in. Now, these tend to be about 2-3 months in duration. Now, this creates a lot more time and energy and cost to it, but the whole goal of it is to eliminate the early non-compliers. It's true for any type of trial design, as you can imagine. It's one thing just to randomize someone and have them assume that they're going to adhere to the intervention or to the pills that they're taking. But by eliminating the early non-compliers, you get a much better trial that comes out of it with much stronger internal validity as a result of it. And in the Physicians' Health Study 2, as well as some of our other trials, we're focused on whether it's major cardiovascular events. It could be cancer. It's also total and cause-specific mortality, eye disease, cognition, and other aspects that are related to aging and brain health as well. Now, as I mentioned, with the Physicians' Health Study 2 and for our other trials, we rely on these calendar packs. I've got one of these from one of our other trials here, kind of actual visual. They're pretty big, right? But we send them in boxes. We'll send them 6-month or 12-month supplies at a time. And the reason why we do in these calendar packs is that we want to promote long-term compliance. Because if you're doing a trial, you need to make sure that we have compliance rates that are going to remain high. And in fact, in the Physicians' Health Study 2 trial, these calendar packs actually become a bit of a badge of honor. They're actually more well-traveled than probably all of us in combination. The participants will take them, at least when travel is a little bit easier, to all parts of the world, take pictures with them, kind of show how they're taking the pills, and we put these into newsletters. And as a result of that, what's nice is that what we've seen, even for our long-term trials, for vitamin C and E compliance, our compliance remained 78% at 4 years, 72% at 8 years. And if you extend that out to the multivitamin intervention, which went actually about 11 plus years on average, even by the end of the trial, after a decade, more than 2/3 of the participants were still taking their pills. The other unique aspect of not just the Physicians' Health Study, but also of our other trials that we've done within our division is that we have essentially, I would almost go so far as to say, perfected this concept of large-scale remote blood collection. It began actually all the way back in the Physicians' Health Study 1 trial that was back in the early 80s, which was testing aspirin and beta-carotene. And what we do now, and I have a picture here that just kind of illustrates what we send out to participants, we create a blood kit or a biospecimen collection kit, send it out to the participants, and ask them to either get the samples collected either through their primary care physician or maybe their medical group. We've also expanded more recently to use things like Quest diagnostics, where you can go to individual Quest sites to get the blood drawn or get the samples collected and then send those samples back. And so it's become a very useful tool for us, even in these large-scale designs, to collect massive amounts of not just questionnaire data, but also biospecimens. But with regard to brain health in particular, the Physicians' Health Study 2, like many of our other trials, has done a lot of work looking at telephone-based cognitive assessments over time. And one thing what's interesting is, and this is just an example of focusing on the vitamin E and vitamin C and multivitamin components, but one thing that we've had as a challenge historically in the Physicians' Health Study 2, and as you'll see, we've changed our approach in a good way, is that these sub-studies typically begin after the trial began. So we get the funding for the trial begins, we're all excited, and we realize, it would be interesting to see how this relates to changes in cognition over time. And as a consequence of it, in the Physicians' Health Study 2 trial, we had these telephone-based cognitive assessments, but they didn't begin until 2.5 years after randomization. So we can think about how that could come into play. But what's nice about PHS2 is that we've completed up to 4 telephone-based cognitive assessments over a 12-year period of time in nearly 6,000 initially healthy men that were age 65 and up. And for each of these, as you'll see, what we typically do is a global composite score that averages these various cognitive tests. So it's TICS, it's the MMSE, it's doing the East Boston Memory Test, it's delayed recall, testing verbal memory, and then category fluency tasks. And as a result of this work, so Fran Grodstein had worked in PHS2 as well as some of our other trials over the years. We typically, again, construct these primary endpoints that are a composite Z-score that combines all these cognitive assessments into a single score. And if we look, for example, at beta-carotene and cognitive function in men in PHS2, now, albeit there was not an overall, there was no overall effect of beta-carotene on cognitive function in the Physician's Health Study 2. However, what's interesting is when you look at long-term treatment assignment, there were some suggestions that even long-term beta-carotene supplementation might be related to global changes in the Z-score that were significant comparing active versus placebo. Furthermore, when we looked at the multivitamin intervention of PHS2 with the same telephone-based cognitive assessments, again, we saw no overall effect. So if you look at the initial assessment, and again, we have to remember that this was started at 2.5 years into the trial. So you do get some concerns about whether there were early effects that might be masked since we're starting our baseline 2.5 years into the intervention. But again, what we had seen in the PHS2 is that for long-term multivitamin use was not significantly associated with changes in the cognitive scores over the course of the trial. Now, the PHS2 is not the only trial that we have here at the Division of Preventive Medicine at the Brigham. The Women's Health Study is another large-scale trial that we conducted, led by Dr. Julie Bering and Dr. Ayman Lee, that was looking at nearly 40,000 initially healthy men aged 45 and up. This was about a 10-year trial looking at aspirin, vitamin E, and beta-carotene. Again, similar types of major morbidity for primary outcomes, also incorporated a baseline blood collection, that same methodology in more than 28,000 women for whom we have a genome health study as well as other biomarkers that have been measured. And again, Jae-hee Kang and others have looked at the question of vitamin E and cognitive function in the Women's Health Study. Again, we do these telephone-based cognitive assessments in more than 6,000 women that were initially aged 65 and up in the Women's Health Study. Again, the same limitation here. These assessments, we got the WHS going, it was doing well. We added an ancillary study that added the assessment starting 5.5 years after randomization. So we have the same issue of we're not really able to evaluate the early effects, only the later effects of these dietary supplements. But again, I'm looking at the same issues, outcomes of general cognition, verbal memory, and category fluency. But again, we also saw here that at least for looking at vitamin E and cognitive decline, there was no effect of vitamin E here in the WHS as well. Now, we learn over time, right, how we can even improve the design of these trials. And actually what we've now designed is what we would, for our future trials, as you see here, is more of a true hybrid clinical trial, where when we're designing the trial and initiating it, all these other mechanisms are being done simultaneously. So whether we're looking at cognition, changes in cognition, changes in other biomarkers, other relevant outcomes for aging and brain health, these are now being built into our trials. And as one example of that, there's our other, one of the other trials in our group, the vitamin D and omega-3 trial, or VITAL, which was led by Dr. Joanne Manson, as well as Dr. Julie Bering. This was a trial testing vitamin D and fish oil in middle-aged and older men and women. So men aged 50 and up, women aged 55 and up. Another unique aspect of the VITAL trial is that they were able to enroll about 20% African Americans. So this is one other aspect of VITAL that's also unique and a very strong aspect of it. Again, median treatment period is about 5 years and change. Treatment ended back at the end of 2017. Follow-up does continue. And what's nice about VITAL is, as that was being designed and developed, there was not just a baseline blood collection, but also follow-up bloods that were collected over the course of over the course of time. We also, for the first time, added a baseline clinic visit, an in-person clinic visit, as you can see here. And in this VITAL...
Excuse me, Dr. Sesso, there's a big black box on your slide that says Cosmo.
Oh, yeah. Sorry about that. That popped up.
Thank you.
Sorry about that.
Thank you.
Thank you, Rudy. Apologies. So one aspect of the VITAL trial, which was an important add-on, was an in-person assessment. So while we can do things remotely, a telephone-based cognitive assessment has certain advantages to it. With the VITAL trial, what we did was we were able to have a baseline clinic visit in more than 1,000 participants, as well as a follow-up visit at 2 years. And there was an additional 4-year visit in a subset of those individuals as well, where we were able to collect a lot of different in-person data. So not just anthropometrics, oral glucose tolerance tests, but specific to brain health. We did a mini international neuropsychiatric interview. We did a 3MS. We also did assessments of physical performance. And that's, of course, layered with all of these other assessments that you see here. So we have a really rich source of data from which we can look at not just how the interventions of vitals, such as the vitamin D or the fish oil components, are related to these outcomes, but also just in general, as an aging cohort, we can look at these data in much more constructive ways. And furthermore, and actually, there was no different than in the PHS2 as well as the WHS. There was also a vital cognition ancillary study of nearly 4,000 vital participants that were aged 16 up. Again, using these same types of telephone-based cognitive assessments, testing each of the interventions. Again, it was another global composite score that was evaluated 7 tests in this instance. These results are actually forthcoming. So Dr. Jae-hee Kang is leading this ancillary study, and will be publishing these results hopefully within the next few weeks or months. So be on the lookout for that. In addition, as you've heard previously through the seminars, Olivia Okereke has also done a lot of work on vitamin D and depression, as you've also heard about previously off of the VITAL trial. Last but not least, there is the Cosmos trial, which is a trial that was led by myself and also Dr. Joanne Manson, who I believe is going to be on this seminar for today too. So this is a recently completed trial of more than 21,000 older men and women. So now we keep on raising the age of the mean age, if you haven't noticed, from trial to trial. The mean age here is actually about 71 years in the Cosmos trial, testing a multivitamin as well as cocoa extract or a cocoflavanol supplement. This was a trial that was about 3.5 years of median follow-up. While we have our major morbidity outcomes for our primary outcomes, similar to VITAL, we've collected bloods at baseline as well as spot urines, as well as during follow-up in nearly 2,000 participants with multiple blood collections longitudinally. And we have a similar baseline clinic visit. And in this clinic visit, again, we have a lot of aspects of cognitive assessments, physical function that were also added, as you can see here. And as was mentioned at the start by Jonathan, also I have an interest in blood pressure, and in both the VITAL trial as well as Cosmos. In these in-person assessments, we also collected not just seated blood pressure, but also ambulatory blood pressure as well. And so there's a lot of and one thing I should also mention, I forgot, is that we also did collect actually brain MRIs as well as part of this in a smaller subset of 120 participants at baseline, of whom 80 of them came back for 2 years and also completed an MRI as well. So there's a rich source of data to build upon here. And in fact, in the area of brain health, there's actually a lot of opportunities within Cosmos in particular, given the fact that we've collected these bloods, again, more than up to nearly 7,000 people at baseline. Of those 7,000 at baseline, many of them have provided multiple time points of bloods as well. We have this clinic subcohort. And then, as you'll see, we have these 2 cognitive-based assessments that were done through 2 separate ancillary studies. One through the group at Columbia University, where they're doing web-based cognitive assessments. Then another group down at Wake Forest that was doing telephone-based cognitive assessments. Again, similar in concept to what you've seen before that I was describing. And in fact, when the trial ended, about 2 weeks ago, Dr. Laura Baker down at Wake Forest presented some of the preliminary findings. These are not yet published, but have been presented at the 2021 Clinical Trials in Alzheimer's Disease Conference, showing that at least for the cocoa extract supplement, as you would expect in these types of trials, you see a learning effect, right? So from baseline going to year 1, 2, and 3, and this is in more than 2,000 participants, both groups went up. Both groups improved in terms of their global cognitive function and Z-scores. There was no significant difference. So while the cocoa extract group, I don't have a label here, but the blue group is those on the cocoa extract. Red is those on placebo. There was a slightly greater benefit for the cocoa extract, was not significant. On the other hand, what we see for the multivitamin, multimineral effect, we do see actually evidence here that those that were randomized to take a multivitamin over the course of the Cosmos trial over 3 years did actually have a greater improvement in the global cognitive function score, their Z-scores. So they had a greater improvement in change from baseline. Furthermore, if you look at some of the more specific components of cognition, so memory or executive function, we see a consistency in the difference where those in the active multivitamin group had a significantly greater improvement in memory, for example, and as well as executive function, excuse me, compared with placebo. So these are results that that Laura Baker has presented recently, about 2 weeks ago, and we're hoping to have these more formally published in the weeks and months to come. And one final point just regarding this, it doesn't look like a big difference in effect, but if you look at this a different way, if you kind of take the global Z-scores, look at it in the context of the estimated treatment effect that we're looking at per year in terms of the difference, there's a suggestion that daily multivitamin supplementation might slow cognitive aging by as much as 60% or about 1.8 years, which is actually quite remarkable for a relatively safe, simple intervention like a multivitamin, and that is easily accessible to an older population. One final point outside of Cosmos, there's another project that I'm involved in that is looking at the natural history of neurofilaments, as well as how it relates with brain health and other outcomes related to aging. It's a data science initiative that we received funding for about a year ago. And what's unique about this project is it's actually pooling some of the samples that I've been describing to you from the Physicians Health Study, the VITAL trial, and Cosmos trial, where we're looking to see how neurofilaments, and specifically neurofilament light as well as GFAP, how they change over either a long period of time using bloods that were collected 14 years apart in the Physicians Health Study, or how short-term changes in these markers might change looking within the VITAL and the Cosmos studies, looking at either 2-year or 1 or 2 year changes, and looking at how these also relate to changes in DNA methylation, epigenetic aging, as well as metabolomics. So this is a project that we're in the active phases on, and certainly looking for other partners to work with us. What's neat about this project is that we're working also closely with Biogen, Nightingale Health, which is in metabolomics, and then Life Epigenetics, which is now called Foxo Technologies. They kind of changed their name along the way, but they're on the DNA methylation epigenetics front. So just to conclude, there's a lot of important considerations when we're thinking about clinical trials of nutrients and dietary supplements on brain health. One thing I didn't get into is the role of baseline nutritional status. That is certainly an important effect modifier that we need to incorporate much more carefully. But the idea of trying to combine these clinical outcomes with mechanisms is something that, in particular, not just Cosmos, but VITAL and even the WHS and the PHS2 can do quite uniquely. And we can leverage the existing data that we've collected, whether self-report, telephone-based, or clinic-based data. We have biospecimens previously collected. We have access to those, as well as for even new or updated longitudinal data collection across our cohorts. And there's a great interest in short-term trials of dietary supplements and brain health as well. I'm actually about to initiate a new trial looking at magnesium and blood pressure in middle-aged and older adults. And there's been some interest in trying to add in some components of cognition, as well as some of the psychosocial outcomes that can be built into that as well. So thank you for your attention. Happy to take any questions that you might have.
Howard, thank you. That was a terrific tour of the richness of the work of your team in this area. And I'm sure there are going to be a lot of questions. I just wanted to start by asking, I think going back to the biomarkers study that you introduced at the end, is this an approach now where you're thinking that you're going to be doing more of these kinds of add-ons, given that we're looking for, as you mentioned toward the end, the shorter term trials? And I wonder if the magnesium and blood pressure trial is, you've chosen blood pressure because you can measure it more quickly than you can cognitive decline.
Yeah, so you've got a few interesting embedded questions there. So for one, what's nice about our Cosmos trial, VITAL trial, and even the Physicians Health Study trials, as well as WHS, is that we have a lot of existing data. And while the trials are complete, the data are still there. And we have longitudinal data, long-term follow-up that are constantly being updated. So we do have the ability, for example, from this project that's looking at neurofilament levels and looking at the natural history of how they change, we do have the ability to do add-ons into our existing projects to measure new biomarkers or to consider new questions or blocks of questions into annual follow-up questionnaires that go out to each of our cohorts. So we're always open to ideas. whether it's for a paper or analyses or a new grant proposal. With regard to the magnesium trial that we're about to undertake, that's actually a second trial. There was an initial trial that we had done that we had seen some potential benefits for short-term magnesium supplementation on blood pressure. This was about a 3-month trial, a 12-week trial. For this new trial, it's also going to be a 12-week trial. So for obviously that type of duration, looking at cognitive change over that type of a duration is going to be more difficult to do. However, in the same time, things like mood, physical function, there are other things that we can incorporate into this trial that we would be very much open to your ideas or input on. There will be in-person visits as part of this trial, so we do have that benefit. The magnesium trial is for us, a relatively small-scale trial of 120 patients, 12 weeks. The advantage of it is that we can, with the clinic visits, we can build in-person assessments as appropriate.
Great. I had offered this chart, but speak up. Yeah.
Yeah. So, boy, that was a great talk. It's, this is really what we need in the field is people doing clinical trials on, supplements, vitamins, et cetera, so that we can add some validity to giving suggestions to folks, about what supplements and vitamins to take. It's what we don't have enough of. And so congratulations on all that. And I think it's great work. It was a great talk. So I have a specific question and a broad question. Specific question is, given the prevalence and incidence of Alzheimer's amyloid and tangle pathology with age, even, in asymptomatic people, some estimate is 38 million Americans that have have amyloid or tangles in the brain without symptoms. Do you have any plans to look at A beta 42 and 40 ratio, as well as phospho-tau and the phospho-tau to total tau ratio and these, I think it would be good. Even though it's Alzheimer's specific, it's so prevalent, it might be another good thing to add to normal aging tracking.
Yeah. So the short answer is yes, we have interest in. Actually, I'm not sure if she's with us today, but Pamela Rist, who's a colleague of ours in the Division of Preventive Medicine, is working on a project in Cosmos to look at some of the amyloid beta components, as you've described. And that is an area that is certainly of active interest to us, given the fact that not just from a longitudinal standpoint in an aging cohort, but also in the context of the dietary interventions that we have tested across our trials, there's a lot of opportunity to look at that. I mean, one of the great parts about these trials that we've been involved in here is that we've done the trial. Yes, it's done, but yet at the same time, we have the ability to go back and test new questions within the trial framework, or it's just within the framework of the longitudinal data collection that we have. Yeah. And to your other question, Rudy, with regard to Alzheimer's disease, we do collect that over the course of follow-up across our division trial cohorts. So across VITAL and Cosmos, PHS, WHS. And so that is also another active area that we can look at in different types of study designs, whether as a nested case control study or case cohort design, where we can look at, it doesn't have to be just biomarkers, of course, but we can look at behavioral risk factors, changes in risk factors over time. There's a lot of different angles that we can do. Another outcome I hadn't mentioned, which we've done a lot of work with, Ariella Orkaby, who's a colleague of ours at the Brigham here and does a lot of work with the Pepper Center here at the Brigham, is also interested in frailties, another area that's been an area of development, both in the physician's health study as well as in the women's health study. And I believe she's also now doing work on that in the VITAL trial as well. But that's another area that we can easily build the data that we've collected into these types of outcomes.
Yeah, and the broader question was just, are you open to testing other supplements? We've been doing natural product screening in our Alzheimer's in a dish model, 3 organoid models, 3D neuroculture models for a long time. And we're planning various types of trials. So it'd be great to, separate from this, is just to talk about some of the natural products we want to start getting tested. And your trial design and infrastructure looks great. It'd be great to think about collaboration with us, also with Stephen Arnold's group, and expand the network.
Yeah, Rudy, absolutely. I mean, this is what we do, right? So we do both large and small and medium size, however you want to define those numbers on these types of trials. And whether it's in the natural product space or dietary supplements, they're all very much conducive to trials, large or small. and whether it's mechanistic or based on clinical outcomes. There's a lot of ways we can go with that. We'd be happy to talk about that further.
Yeah, I think we can set up a Zoom and just we can show you what we're doing in that space and some of the other biomarkers that we do as part of McCance. And yeah, it'd be great to work together on this. It's wonderful.
Sounds good.
Well, we have time for one more quick question before I turn the platform over to Rudy. Anyone want to speak up? Okay. Well, Howard, yes.
Oh, okay. If there are no other questions, this is Joanne Manson. I just want to mention that Pamela Rist and I, as Howie alluded to, are planning to look at these amyloid disease biomarkers. And we do have funding from the Women's Brain Initiative at the Brigham to look at about 600 participants from Cosmos at change in light chain neurofilament, amyloid beta, and different components of amyloid beta, as well as N-terminal tau, which Dennis Selko does a lot of research on. So 2-year change. And this will enable us to look at this finding with the multivitamins, whether there was any change in these biomarkers with multivitamins or with the cocoflavanols. Should be quite interesting.
That's fantastic. It's great.
Okay, well, we will have a follow-up conversation, I'm sure. Thank you, Howard and Joanne and Pamela, for joining us